Greetings, I'm Jim Shea with the Acoustic Neuroma Association, and I'd like to welcome everyone to our 2023 ANAwareness Week. In a moment, we'll hear from Dr. Desi Xu with the Ohio State University Wexner Medical Center and his presentation of Imbalance and Dizziness after acoustic neuroma surgery, what to expect. Before we meet Dr. Xu, just a few quick notes. If you have a question during the presentation and you're joining us on Zoom, you can just write that in the Q&A section, which can be found at the bottom of your screen. If you were joining us on Facebook, your questions can be written in the comments section. We may be able to have questions answered as we go through the presentation, but afterwards we will get to as many as we can. Captions are available for this presentation. You can turn those on at the bottom of your screen as well. This presentation is being recorded, and you'll be able to find this in our webinar library on the ANA website at anausa.org. That's also a terrific resource for so many topics you may have an interest in. There's a search option in there so patients can find just what they're looking for. Lastly, a reminder to keep an eye on our social media this week especially. We're on Facebook, Instagram, LinkedIn, and you can learn all about the resources available and how you can be more involved with the ANA. The ANA is here to help, so please access those opportunities. And now, Dr. Xu, if you'd like to introduce yourself, we can get started.
Perfect. Hello, I'm Dr. Xu. I'm an assistant professor at the Ohio State University Wexner Medical Center in the Division of Otology, Neurotology, and Cranial-Based Surgery. Give me 1 second while I share my screen. Sure, there we go. And again, I just wanted to take the opportunity and thank the Acoustic Neuroma Association for inviting me to talk today and for all the resources they provide to you, the patient. I think it's really amazing. Opportunity to have to be able to talk to you all and really kind of share what is a passion for me, which is how do we manage and how do we improve dizziness and imbalance after acoustic neuroma surgery. And one of the things that stands out to me or stood out to me is always that patients are a little bit surprised not only about what they experience after surgery, but also what they experience long term. And so really today, I hope to provide some background and some information and hopefully a little bit of, I guess, heads up or at least what to expect as far as what you may experience. And so, I'm really excited to be here. I have no disclosures to report, sorry, with this presentation. So I think we should start at the beginning, really, and that is to discuss dizziness and what is dizziness. And one thing that always strikes me, especially as a clinician, is the fact that dizziness is actually quite an imprecise term. And it's really hard when patients come to us and say that they're dizzy, because dizziness really could mean a number of different things. And so what our job is really to be almost the investigator here and try to figure out, what is the patient talking about? Are they talking about vertigo? And that's often experienced as a sensation of motion. Most people will experience a spinning or tumbling, but it can also be a swaying or almost like a pushing motion. And then there's also disequilibrium, which is generally a sense of imbalance. And that can be either while standing still or while moving and walking. It can also be triggered by visual backgrounds or patterns, and all of these kind of give us a sense of where to look to find the answer, where to try to, how we determine what may be happening. And then the last two are other things that we at least need to be able to identify. That way we can rule them out, because they often aren't related to the inner ear in as far as vertigo or dizziness is concerned, but may actually be warning signs for other types of conditions. So lightheadedness and pre-syncope, which is actually kind of that sensation of feeling as though you're about to faint or do faint. And so again, dizziness is an imprecise term, but often when we're talking about dizziness, we're talking about balance. And this is just a quick kind of diagram that really shows what is balance. And this, I think, helps to get at the core of why dizziness as a symptom is also so complicated and complex. And really what this is showing is that we have a number of different systems that play into our balance and our sensation of stability. And that includes sensory inputs, Again, kind of close and dear to me is the vestibular system, the inner ear. And this gives us a lot of inputs as far as head motion and head position in space. But we also rely on our eyesight and our visual cues to help tell us, where we are in the environment and help to kind of also double check to make sure our other systems are providing us with good information. And then finally, one that sometimes is underappreciated or overlooked is the proprioceptive, or kind of the sensory aspect of our sensation. And so this is really kind of where our joints are in space, where our limbs are in space, including our trunk, the center of our body. And again, all three of these sensory input systems work together almost in a checks and balances way to feed information centrally to the cerebellum, which really is the black box of the balance system. And so the cerebellum takes all this information in and either sends out reflexes or finishes reflex arcs, or sends the information up higher to the cerebellum or to the cerebral cortex. And then again, all of this kind of, after it's been processed centrally, comes back out, and then we get motor inputs, or we have actual kind of effects of that balance information. And so one we'll talk about is the vestibulo-ocular reflex, and that ties eye motions very closely to what the ear senses as motion, as well as motor inputs or motor impulses, which help to either control the eyes, keeping vision stable, or even our limbs and our trunk to help kind of keep our stability and our posture. And so again, all of this kind of combines this very complicated system and is kind of what we experience as balance. And so really, it's important to realize that this is very complex, and any issue or breakdown in any one of these areas can give the sensation or give the experience of being dizzy or imbalanced. And again, our role is to be the investigator and really try to figure out which of these issues is going on with any one patient when they come in with a balance disorder or dizziness. So then to zoom in closely to the vestibular system, which is where both the acoustic neuromas have an important role, and where I play an important role as a clinician, is to really look at what are evolutionarily our motion sensors, our inertial sensors. So they sit in our inner ear, and signified by the red arrow or the red circle here, adjacent to the cochlea, so adjacent to the hearing organ. Is this cluster of organs, and these are all enclosed in the dense bone of the otic capsule, or the inner ear. And so that system is paired, meaning each ear has one. And on each side, there are three semicircular canals, which are here. And the semicircular canals are responsible for sensing rotational head movement. And the way they're organized and oriented between both ears, it really is able to sense rotational head movements in any direction imaginable. Next to those, and similarly next to the cochlea, are the utricle and saccule. And these are our linear head motion sensors. And so these help us to, sense, for instance, when you're riding an elevator, and part of that sensation of when the elevator goes up or down, you sense it, or when you hit the accelerator in your car or in a plane while it's taking off, it'll stimulate these sensors. Importantly, the utricle plays a role in actually sensing gravity, and that helps tell our brain where our head is in space. And so it lets us know whether we're standing up, if we're tilted to one side, or we're laying down. And similarly to the semicircular canals, these two, what we call the otolith organs, actually provide linear acceleration information in any direction that the head can move. And so these systems combined relay this information to the brain and to some reflex arcs. And again, this all kind of comes together to help stabilize our vision and to give us a sense of balance. And one of the things I think is especially important to point out is that vestibular sensation, if everything is working well and the ears are not having any issues, is actually completely unnoticed. Some people call it the sixth sense, as a kind of an overlooked or unseen sensation that we have, as important as vision and hearing and our taste and touch sensation. But we definitely notice it when something's going wrong. And so that is when we usually see patients. And so I think part of this that's so confusing is because it's not there and not at the forefront of our sensation. When we do experience imbalance and dizziness, it is quite debilitating. And I think looking a little bit closer at how the vestibular system actually signals motion will help us to understand, especially in the instance of acoustic neuroma, especially after surgery, why we experience what we experience. And so vestibular signaling occurs at kind of the sensory centers of each of those end organs, the 3 semicircular canals and the 2 otolith organs in each ear. And these little sensory hair cells respond to motion within fluid motion within those systems. And that matches the head motion. And so when these hair cells, the ends of these hair cells, move in a way, one way or the other, for instance, it signals from a neuronal perspective whether there's an increased firing rate or a decreased firing rate. And so our ears at baseline have kind of this balanced level of neuronal signaling. And so when you're sitting very still, the signal from each ear is exactly the same. And that tells the brain that you're sitting still. It tells your eyes that you're not moving. And so how that changes is when you move in one direction or the other, say towards the right, the signaling in that ear goes up. And that imbalance, because the signaling in the opposite ear, the left ear, will actually go down a little bit. That asymmetry in the signaling with the head movement is what the brain is using to interpret head motion. And that drives, again, reflexive eye movements. It also drives other reflexes that help maintain our posture. And so importantly is that from a signaling perspective, the brain is very simple, and it is in some ways kind of foolish in that any asymmetry it sees, it interprets as head motion. And so whether that's from spinning quickly in a circle for several seconds and then stopping, you'll get a sense of dizziness from that. Or again, in the instance of a acoustic neuroma, if there's an imbalance from either the tumor or from the surgery, the brain kind of always interprets that as motion. And I've kind of alluded to it or mentioned it a couple times, but we have this important reflex arc that ties our vestibular system to our eyes and our visual stability. And it's called the Vestibulo-ocular Reflex. And this is an important and actually a very, very fast reflex. It's the fastest reflex in our body. It takes anywhere from 5 to 7 milliseconds to complete. And what this does, its main role is to stabilize vision, or to actually create an eye movement that's equal and opposite in size and speed to the head motion. And so what this does is really allows us to read, our phones or signs as we're walking. It allows us to turn our heads quickly when we're driving without jumping off target if we're looking at something. But this is also the cause of one of the main symptoms when there is dizziness or vertigo, which is nystagmus, this kind of stereotypic bouncing eye movement. And from a patient perspective, that feels often like the vision is bouncing or difficulty kind of staying still or focusing. And from a clinical perspective, it actually gives us a lot of information about what's happening in the ears when it's present. And so we look closely at the eyes to tell us what the ears are signaling, whether it matches what we would expect, or whether it's possibly showing us something different. And so, all of this information comes together to, kind of build this kind of foundation of what we expect to see in our patients with acoustic neuromas, both before surgery and then after surgery. And so, as many of you are likely aware, acoustic neuromas are also termed vestibular schwannomas, which is probably a more appropriate term from an anatomical and pathological perspective, because these growths are benign tumors, and they actually arise from the Schwann cells, which are the supporting cells of the vestibular nerves. And most often they occur sporadically, and they affect only one ear. In almost all cases, they present as an asymmetric hearing loss, so that's what the patients experience the most. But it can present as a chronic or intermittent dizziness or imbalance. So it's something that we always kind of have on our radar when patients present with asymmetric hearing loss or dizziness that just isn't well explained by other means. And so part of the reason why I think that these patients that present with asymmetric hearing loss as opposed to acute spinning vertigo or dizziness is that oftentimes as the tumor grows on the vestibular nerve and impacts its function, that can occur very slowly and over time. And as I showed you earlier in the presentation, the balance system has so many inputs that as long as that change is slow and as long as that change occurs steadily, meaning not fluctuating with a lot of undulations or changes, then most people can kind of compensate slowly. And so some patients have vestibular dysfunction at the time of presentation, but don't really necessarily notice that, although we're able to see it on testing and on our clinical exam. And so once a patient is diagnosed with acoustic neuroma, we always discuss all the treatment options, including observation and close follow-up through imaging studies, microsurgery, which is kind of the topic of today's talk, as well as radiation. I think each kind of plays a unique and important role in the management of patients with acoustic neuromas. Again, for the purpose of this talk, we talk a lot about microsurgery. Why would somebody possibly choose microsurgery? I think in part because it allows the definitive treatment of the tumor. It kind of take a big risk a larger risk up front, but it then kind of takes care of the problem for the most part long term as far as the tumor is concerned. It also, from a balance and vestibular perspective, it actually gives our patients an opportunity to have a new baseline, a new starting point to then build from. And so observation and radiation therapy often will continue to have declines in vestibular function, and patients will over time experience increasing imbalance. But that pathway, that trajectory can look very different. And so there's no right answer. There is, we always talk about the risks and benefits, and we try to really help our patients to choose what aligns best with what they care about and what's important to them, as well as in certain instances, what our literature and kind of our best practices tell us are likely going to be the best options moving forward. And so microsurgical resection, it's important to realize that with surgical resection, independent of the approach, the vestibular nerves on the tumor side are cut and removed with the specimen, with the tumor. And there are two of these nerves. So oftentimes we term or we think about it more as the eighth cranial nerve or the cochlear vestibular nerve. But that nerve branches into a cochlear nerve and then two vestibular nerves. And so while the tumors almost always grow off of just one of those vestibular balance nerves, in the area of the internal auditory canal, which is where these tumors tend to grow, it's often difficult to really separate one from the other. And so they're almost always both removed. And as I mentioned before, the brain actually just sees this as signaling, from a signaling perspective, neuronal signal, as though the opposite ear is being stimulated, because by cutting those nerves, we drop that signal on the operated side down to 0. But the opposite side is actually still functioning at its normal level. And so that's interpreted centrally as either your head is being tilted towards the good side, or that you're spinning or turning towards the good side. And so that really kind of helps us to determine, exactly kind of what we would expect to see in our patients. And so what do we expect to see after surgery? Well, many of our patients report dizziness, and often it's a sensation of spinning, again, or tumbling motion. And so we would term that vertigo, especially from a vestibular origin. That vertigo, again, causes the vestibulo-ocular reflex to initiate and causes nystagmus, which again is bouncing vision. And so patients tend to tell us that their vision seems to bounce. And it actually is a little bit worse when they look away from the surgical side. And so, depending on where we stand in the room or where you're focusing on in the room, you may notice that your vision is more or less stable, just based on that. We expect everybody to experience some level of imbalance or disequilibrium after surgery. Again, this is a big shift, a big change in how the brain is getting signals about where your head and the rest of your body is in space. And so it's not uncommon to experience that type of sensation. And then interestingly, some patients actually will experience double vision, and it's often in a vertical double vision. And that's from some of those, the gravity sensor essentially feeling or being tricked into thinking that your head is tilted off to the side. And so it'll try to fix that with the eyes by pulling one eye a little bit further up than the other. And you see that as two objects, for instance, a clock that appears double and one is slightly above the other. And then, unfortunately, some patients will experience nausea, and some will also have some vomiting. And so, I'm going to show you first kind of what we see when we look at the eyes of patients, and then we'll talk more about what can we do about some of these symptoms. So this is a great video. Dr. Dan Gold is one of the neurologists at Johns Hopkins, and he's provided some videos to the Utah collection of eye movements. And so this just shows the typical nystagmus or beating, bouncing eyes that we see with vestibular dysfunction. And so in this patient, their eyes this is done in the dark, so they don't really have anywhere to fixate on. And you'll see just this little, almost like a ticking motion of the eye. And that's what we call nystagmus. And that's what we see in our patients who have had a vestibular schwannoma or acoustic neuroma resected. And this is really allows us to tell that the patients are likely feeling that dizziness and are sensing that bouncing vision. And interestingly, this would be kind of looking towards the good side. The eye movements is speed up a little bit, and then you'll see in a moment when the person looks away towards the right side, that actually slows down and it's minimized. And so again, you may notice that depending on where you look in the room or where people are standing when they talk to you, that the vision is a little bit more or less bouncy. And that actually may also play into how much dizziness and nausea you feel. And so it's important to keep in mind that every patient's experience is different. And so it's really hard to tell preoperatively who's going to have a lot of symptoms and who's going to have few or no symptoms. And this is likely related to a few things. Primarily, it's probably related to the residual vestibular function in that ear before surgery. Like I mentioned, if there's been a large kind of decrease in that function over time, the task of cutting and removing the vestibular signal with the tumor on that side likely won't feel that much different to the patient. Similarly, if there's a lot of inflammation from the tumor or the growth of the tumor, and the balance function in that ear is kind of changing frequently, and the brain really can't trust or rely on that signal, then sometimes just giving the patients a more baseline or standard signal by removing the tumor will actually feel overall better than not being able to really tell whether or not the signal from the ear is correct or trustworthy. And so that's also important. And again, the rate and change in the symptoms. And so if there's a lot of symptoms that come on quickly, then or if there's been a big change recently, the brain may not have had time to compensate and adjust for those changes. And so those patients may be a little bit more likely to experience those symptoms. And then there's other factors that we have to consider, including the age of the patient, other medical conditions, vision loss, anxiety, depression, if they have migraine headaches, which is a big driver of dizziness in the general population, and other things like peripheral neuropathy. And so the visual loss and the peripheral neuropathy kind of go back to that first slide, where these are other inputs into our balance system. So if you're having problems with these systems, then you may actually have a harder time after surgery making these adjustments. And so, and the other important thing is I mentioned age, is that as we age, our sensory systems decline as we get older, and so it's just more likely that the vision is declining, and that the other sensory organs and other central kind of processing mechanisms are just a little bit slower and may actually cause a little bit more symptoms for the patient. And so, what do we do with to help treat these early symptoms and help to relieve what the patient's experiencing? And so there's anti-nausea medications that we can give if patients are experiencing nausea. Ondansetron and Phenergan. I like Phenergan particularly. It seems to work a little bit better for the inner ear related nausea, the nausea related to vertigo. Ondansetron is always a good medication to have. That tends to work a little bit better in addressing what we'd consider a kind of chemical sensors, so post anesthesia related nausea. And these medicines can be used together. And so when you're after surgery and recovering either in the postoperative area or the intensive care unit, you'll likely receive one, if not both of these medicines, just to kind of help you manage those early symptoms. If symptoms are especially severe, sometimes we'll consider vestibular suppressant medicines. What are those medicines? Those medicines are things like scopolamine and benzodiazepines. We often don't use them early in the course, and if we do use them, we use them pretty sparingly. In part, that's because all of these medicines that kind of slow down the vestibular signaling, slow down the central signaling as well. And so patients experience that as being sedating and sleep, driving sleepiness. And these are all things that the ICU is watching very closely for as signs that maybe there's a complication. And so often in the ICU, we don't use these medicines. In the long term, these can actually also impair how well people are able to rehabilitate and recover their balance function. And so only in kind of very, very rare cases of quite severe symptoms would I consider using a vestibular suppressant medicine in the early treatment of symptoms. And then what else helps? Time helps. Not everybody likes to hear that, but it's true. Our brain actually does this amazing thing after the first 1 to 3 days of witnessing this mismatch between what it's experiencing with all the other sensory systems, the fact that you're sitting in a chair or laying in a bed but not moving. Your eyes are telling you that the environment around you is not moving, but your ears are telling everything else that you're spinning. Well, your brain kind of resolves that mismatch and calms down the balance system and says, okay, you're not spinning. And so you stop feeling like you're spinning and your vision steadies over time. And so things that help that happen is spending time awake, spending time looking around and kind of experiencing the environment can help to kind of recenter the brain. The brain really doesn't like it when things don't make sense. And so it pretty quickly will calm that down. And the other thing that we always do early on, usually within the first day after surgery, is start physical therapy, specifically vestibular rehabilitation therapy. And early on, this may look like just safely sitting, standing, and walking, but then later we'll develop into exercises kind of focused on rehabilitating the balance system and how do we improve gaze stability and other balance and kind of walking tasks for you. And so vestibular rehabilitation therapy is anymore kind of a set standard of treatment modalities. Different exercises may be employed at different times, but really what we're trying to do is we want to create those sensory challenges. We want the brain to experience that the ear is giving it a bad but consistent signal. That way it can start relying on other things. And so again, to recall, on the side that had the tumor that was removed, although there's no function on that side, the other ear is still signaling. And so it can signal kind of half of the head motions that it normally would, including kind of decreasing some of the signal. But importantly, all those other systems should still be up and running. The visual cues, the proprioceptive or somatosensory cues from the joint sensors and the arms and the kind of positional sensors from the arms and legs. And so one of the main exercises that physical therapists use is what's called gaze stabilization exercises. And so this is one example of that. And at its kind of most simplest experience or example is to kind of hold your thumb out in front of you, focus on your thumb, and move your head back and forth while focusing on your thumb. And what that does is early on, your eyes will not stay perfectly aligned, but over time and over practice, your brain will start using other systems, stretch receptors in your neck, signaling from the other ear, as well as the slight slip from the visual field to tell the eyes to move a little bit sooner, maybe a little bit further, to try to really stabilize that view while you're moving your head back and forth. And then the other thing is just kind of along those same lines is especially with walking and different posture-related tasks is sensory substitution. And kind of the same thought process is you're really challenging through either dynamic, meaning kind of moving tasks, either gait walking or standing, and challenging postures to kind of support the brain's compensation or adaptation to use other systems to really drive improved posture control. And so that will help with the imbalance and disequilibrium quite a bit. And so vestibular rehabilitation therapy is really the mainstay of treatment after surgery as far as making people feel better and hopefully making that improvement last for a significant amount of time. And so next, we should talk about what happens after surgery. So most patients stay in the hospital from, depends on everybody's postoperative course, but a few days, usually 3 to 5 days, and then they're ready to go home. Well, the therapy doesn't stop at the end of the hospitalization. It's one of the most important things to continue after the hospitalization. And so that usually looks like 1 or 2 sessions a week and can last anywhere from 6 to 8 weeks. Every therapist kind of does a different system, and a lot of it is feedback from how well the patient is doing and how they're responding to treatment. And so, another thing that I always think about is that physical therapy in these instances is you have to almost think of it as training for a sport or a sporting event. Practice really is important. And so it's not just those brief sessions in front of the physical therapist, it's everything you do in between those sessions. So staying active, practicing, doing the exercises that they prescribe is probably the most important task. Some research has shown that it's not just how long you've been doing therapy, but how frequently and how kind of long each period of the exercises are. So it's really important to kind of give that time to the exercises to get better. And again, important to realize that even ongoing moving forward, the brain needs to kind of see those sensory mismatches to really make the changes and improve the balance signaling that you get. And so I always tell patients that it's okay to feel a little uncomfortable when you do therapy and your exercises. We don't want you to feel unsafe and we don't want you to hurt yourself, but we definitely want you to feel a little uncomfortable and uneasy with some of the sensations that you're experiencing, and because that really drives that central adaptation and compensation and will overall make you feel better faster. And so the other thing to keep in mind is just, these surgeries are big surgeries. It takes quite a while to recover from. And so, we always say be as active as you can. You should try to resume your normal level of activity, but you should do it safely and slowly. That way you don't have an injury early that could potentially be problematic and devastating. So, there's kind of this fine balance of moving things forward and being as active as you can be. And so then the next topic that I really wanted to cover, and I think gets asked a lot, is what happens for some patients who don't get better, who have persistent symptoms, weeks, months, sometimes even years after surgery. And so I think especially in the acute period in the first several months, be mindful that it can take 3 to 6 months before you really start feeling that you're kind of reaching a plateau or getting back to maybe how you were feeling before surgery. And you should know that if things don't seem to be going in the right direction, that's an opportunity to touch base with the physical therapist and discuss, ways to either improve the targeting of your therapy, which exercises you're doing it, the frequency of exercises. Oddly enough, in some instances, if the brain isn't working or isn't playing nice with the rest of the body. Sometimes too much therapy can kind of stall things out. And so it's really about kind of touching base and making sure that you're on the same page with your therapist and that everything's been optimized. You should also consider being evaluated by a physician, either your otolaryngologist, your neurotologist, or another specialist who kind of specializes in balance dysfunction, to see if there's any possible other overlap. And so a good place to start is with your primary care provider, just to see if there's anything that can be optimized. And so things like just general changes in health as we age, or changes in vision or other sensory systems that sometimes can happen with long hospitalizations, or with, just as we age, can sometimes kind of show up unexpectedly. And so it's a good chance to say, is my blood pressure control okay? Has my vision changed any? Am I showing signs of any other issues like peripheral neuropathy if you happen to have diabetes or another condition like that? You also want to make sure that you're not taking any medicines, which may actually be sedating, and sometimes these medicines will pop up, sleep aids, some muscle relaxants. And so these medicines can all kind of slow down and stall out that improvement process. And so we want to be sure that if those medicines can be reduced or stopped, that they are, to really give you the best opportunity to improve and to have your balance, kind of stabilized. Headaches, especially vestibular migraines, can be a big driver of this, and something that we should always think about in a patient with a headache history. Over time, what we're learning is that patients with migraines, their symptoms change over time, and almost the headache component kind of burns out or fizzles out, and what's left is this kind of dizziness experience, and that can happen in the presence of vestibular dysfunction, as in patients after surgery. And it can actually be triggered sometimes by a surgery, intracranial surgery, and especially when there's been a big change in the vestibular function. So we should always at least consider that, because there are ways to treat that, both in lifestyle, diet, and other lifestyle changes, as well as certain medications. And then we should also make sure that we're not missing something else that may be underlying some of the issues, like anxiety or depression. Interestingly, some of the medicines that work really well for the migraine-related dizziness and vertigo also help to treat anxiety and depression. And so there can be definitely some, not just overlap in the treatments, but overlap in some of the symptoms. And so we just need to be aware of all the possible causes of dizziness at this time. And then again, other possible causes of dizziness, it's definitely possible to have a problem with the opposite ear, the most common one being benign paroxysmal positional vertigo, which is dizziness that's usually related to laying down or rolling over at night. And that can be pretty easily treated by a physical therapist or by a physician. And then the other thing, which is similar in experience, I would say, to the vestibular migraine, which is persistent postural perceptual dizziness, is kind of this general sense of imbalance and unease and dizziness that doesn't really match up with a lot of things. And so patients will often describe that they only feel better when they're sitting very still and not moving. And if they're moving at all, there's a lot of symptoms. They also notice some sensory, overloaded and busy environments or busy backgrounds. And so that can kind of give us some clues. The way I think about triple PD, it's almost like the brain is mounting too aggressive a response to the change in the vestibular function. And so it's almost overreacting to everything. And that can almost be counterproductive, especially in balance therapy. And so just being mindful of that. And sometimes we treat that with medications. That's one of the conditions that sometimes I'll say, let's try to treat some of the symptoms with medications, step back from the physical therapy for just a little bit as those medicines are starting to work, and then reintroduce the exercises as some of these symptoms improve. And then one of the other topics that always comes up when I talk to patients is, well, what happens years down the road? Will I ever feel normal again? And so it should, I would say that it's reasonable to say that most patients are able to regain a very similar activity level and quality of life as they had before surgery. But they should be aware that there is going to be some persistent symptoms after surgery. And so even after complete kind of maximized balance rehabilitation, you'll always notice that when you turn quickly to the side that you had your surgery on, that your visual field will probably slip for a moment or two, and that may be a little disorienting, especially if you're changing positions quickly at the same time. And the other thing is that it's not uncommon for patients to have imbalance, especially in dark environments. And so the thing I think about most is, for instance, when you're getting up to use the bathroom at night, this is the time to kind of recognize those things, because you may want to try to remove certain hazards that may be in your way, like a carpet, a rug, a footstool. Similarly, some patients will opt to have handrails placed just to kind of give them a little bit more stability. And so it's not uncommon to experience these things long-term after surgery. And the other thing to be aware of and to really kind of highlight is that you have to be vigilant. While most patients, in fact, feel better and get better with vestibular physical therapy, symptoms can return. They can return, months, years, decades later. They can return after things that seem to not be a problem before. And this is usually related to some stressor, whether it's an illness or a prolonged period of inactivity or decreased activity. Or other sensory changes. Again, as we age, our our vision decreases, and some of our other sensory systems start to decrease as well. And so symptoms can definitely come back. And so I always advocate my patients to have a very low threshold for visiting a physical therapist again, or even restarting the therapy, the exercises at home, to try to really combat this. And so it's one of those important things that occasionally we see patients who come back decades later and say, I was doing really well, but then, I had the flu last, month, and I just haven't been the same since. And so that's an opportunity to say, well, have you restarted therapy? Have you talked to a physical therapist? Because you can definitely continue to get improvement in the future with, several rounds of physical therapy if needed. And then the last topic that I really wanted to touch on today is this concept or idea of pre-treatment. So is there any benefit or opportunity in meeting with a physical therapist before surgery, before the resection, to actually start some of the rehabilitation exercises? And so this is an area that hasn't really been well studied yet. I think that it will be studied in the future, and I think that that there's probably an important role for this. It may not be in the way that you would consider, but I think that it's important for a few ways. Really, it helps you establish care with a physical therapist before treatment, and so sometimes that can just help kind of get the relationship off to a running start after surgery. In general, physical therapy, especially balance retraining, can really help anybody's balance. And so even if you're starting with a little bit of balance dysfunction before surgery that you may or may not recognize, your balance will improve a little bit and will kind of get you to start off at a higher point than maybe you would without it. And then the other thing that's probably very underappreciated is actually reducing the number of things that you have to learn after surgery in the hospital. And so anybody who's had surgery before or has been through a medical system knows that there's this information overload that occurs, especially as you're kind of transitioning phases of care. So going from being in the hospital to being at home. And so the nice thing about starting vestibular rehabilitation therapy before surgery is that you get to learn some of those exercises. And so it's you get to kind of decrease that load or that burden of having to learn those exercises. And then finally, I think it's so important to find a local vestibular physical therapist or a physical therapist who specializes in balance retraining. And these are two websites that provide kind of provider searches and directories that I think every patient should be familiar with, because not everybody lives in the same city as a large academic center or with all the same resources as we have here. And so this can help you find somebody local. These are really, again, going to be your coaches, the people that you see frequently after surgery, the people that you check in with frequently. And so finding somebody that's convenient and easy to go to is very important. Thank you. This is my email. Please feel free to reach out, and I'll try to address any questions we don't answer during the question session. And then also, if there's any concern or interest in being evaluated clinically, I'm happy to help help your transition through our system.
Dr. Shu, that was a terrific presentation. That was very comprehensive. You answered a couple of questions that as I was going through it, I thought, oh, we're going to have some questions here. If you want to stop sharing your screen and you
Sure.
just you and I, and we can, there we go. And we do have a couple of questions. The first one I was going to ask was about what you can do before treatment, which was great. That's the last one, the last point that you made. The other one is we have a couple here. Is dizziness associated more with a particular treatment? I know you mentioned that there are a lot of similarities during each surgery, but within the surgeries or with radiation, is there anything?
Yeah, not so much as far as the surgical, the different options for surgery, especially again, one of the steps or main portions of each surgical approach is to kind of get to the tumor and then resect and remove the tumor. And so only in very rare cases are kind of the two vestibular nerves so clearly visible that maybe you could consider leaving one behind, perhaps. And even there's some old teaching that would suggest that that may actually also cause some problems with acute dizziness. Now, as far as the other treatment modalities, observation again isn't likely to cause a big change or a sudden change in balance function, but over time, as that tumor changes or grows, there's a likelihood that you may experience dizziness in the future. And it's hard to really predict that. And similar with the radiation therapy, I'll say first is, personally, I don't have a lot of experience following patients after radiation, but from what I've heard and from what I understand is that the dizziness can happen in a delayed fashion, meaning that it's not as immediate and obvious as it is after surgery when we're making that sudden acute change. And so there's just, again, a little bit more of an unknown factor with how the dizziness will be experienced or how it may present. And in that, there may not be a lot of dizziness after radiation therapy, or it may come, several weeks to months afterwards. And so it can introduce a little bit of an unknown as far as how to approach those patients or treat those patients.
Okay, as a sort of a follow-up, a question from another patient, is it better to go ahead and get the surgery to do a reset of the balance system, or would it be, I guess, would it be okay to adjust slowly while you're observing all other things, not,
Yeah.
in terms of vestibular versus is your tumor growing and what it's doing?
So it depends. It's a really tricky question. And so, what I tell all of my patients is that at the point of diagnosis, there's no way forward that doesn't come with some risk, including observation. And so, our task is really to balance all the risks that are floating in the air. And so as far as the balance function is concerned, is that in some ways, yes, patients will possibly maintain a kind of a better balance function longer if we observe it, or if that gradually changes, they'll compensate over time and may not notice it. But other things can be happening at that same time. I think if you ask, a physical therapist, and I think I also agree with this as well, is that part of the reason why starting at a new baseline, even if that baseline is zero, which in kind of technical thought wouldn't be the best option, it's a very reliable signal to the brain, and sometimes either through radiation or through observation, just having changes in the function possibly related to like tumor growth or inflammation can actually make that signal much less reliable. So some patients actually become more symptomatic as the tumor kind of has its local effects on the nerve.
Oh gosh. Okay. You also mentioned vestibular therapy and being very conscientious about that, and that it's just to reinforce that this isn't something that's better with rest.
Mm-hmm. Yeah, it's so important. It's not a passive thing. It's not even like, certain physical therapy, exercises or approaches for other ailments, perhaps, where you go into the therapist a few times a week and do your exercise and go home and rest everything. This is really an active participant, sport. You need to really, participate both during the sessions, but in between is probably the most important time, because it's really all of that information that the brain has to process between the sessions that really help to drive your ability to regain your balance.
Sure. Patient asks, have you found that any of your patients have been helped by practicing yoga for balance?
Yes, I've only had a few, but I think anything that really challenges the balance system, and I think if you speak to a physical therapist about this as well, they would agree. Tai Chi, yoga, anything that's safely challenging your balance and your posture will benefit your general balance. I will say though that I wouldn't replace the exercise, the gaze stabilization exercises, and some of these other treatments that are specifically prescribed by the physical therapist only with yoga, because I think it all has to work together, and it will. But you have to kind of do the homework and also do what you enjoy or do other things that are challenging.
Sure, it's an add to, not an instead of.
Yes, exactly.
And is there anything new, patient asks, is there anything new in terms of alternative therapies you consider, acupuncture, supplements, anything going on there?
I think certain things like acupuncture can be helpful and beneficial. Sometimes the benefits aren't necessarily at relieving specifically what's driving the balance, but it may be relieving something else that's playing a role, such as neck strain or certain muscle aches or joint aches. And so I think there's definitely a role. It just probably won't treat the core cause of your symptom. As far as supplements go, I'm a little wary of adding supplements, except for there's some really good data to suggest in patients with migraine-like dizziness symptoms that certain supplements like riboflavin, CoQ10, and magnesium can really play a beneficial role in helping to minimize symptoms and to help control kind of their migraine symptom profile. And so in those instances, when I identify a patient who has a strong history or symptoms that kind of are suggestive of migraine, I will recommend supplementation and dietary changes as well.
Okay. Are there things that make dizziness worse, like at ordinarily appropriate amounts of, say, caffeine? Anything that you found that people just do in general? You're like, well, stay away from that for a little while.
Yeah, I think that things that may not be on the kind of the top of the radar, but are definitely will play a role. Alcohol is a big one for sure. So alcohol acts centrally the same way that a benzodiazepine would, which is a class of medication that sometimes is used for acute vertigo. And really what it does is it slows down the central nervous system in the processing, and that can really delay and interfere with the rehabilitation. Caffeine, again, some people are more or less sensitive to that. And so I think that the biggest thing is if you're not having problems with your level of caffeine intake before, kind of keeping a stable level is probably okay. And then being mindful that if you do make any big changes in how much or how little caffeine that you're drinking, that may present itself in a different way now with your balance system.
Okay. All right. Those are all the questions we've got. Dr. Hsu, thank you so much. We really do appreciate what you're doing, and of course, what OSU Wexner does for us. You're terrific partners with us. This was very, very interesting, and I thought there were terrific questions from the crowd. So thank you so much for doing this, and for everyone out there, thank you for watching. Welcome to ANAwareness Week. Okay. Thank you, Dr. Hsu.
Yep. Thank you.
Bye-bye.